Hello, everyone. My name is Flávio Rezende. I am a neurologist, professor of neurology at Federal University of Rio de Janeiro. First, I would like to thank the scientific committee of the Second Palliative Care Congress for inviting me to conduct this session and this interview. This activity inaugurates the pre-congress course on medical cannabis, and I'm very, very honored to be here today. Today, we have a very, very special guest joining us, Dr. Russo. Dr. Russo is one of the world leaders in the field of medical cannabis, and he has a fantastic biography. He served as a senior medical advisor and study physician to GW Pharma, and he was in charge of numerous phase 1 and 3 clinical trials of Sativex for alleviation of cancer pain unresponsive to optimized opioid treatment. Dr. Russo is a board-certified neurologist, psychopharmacology researcher, and author. He is the founder and the CEO of Credo Science. So Credo in Portuguese, Dr. Russo, means acreditar, which means believe. So we are all believers. That's why we are here today. Thank you so much for being on board today.
It's a pleasure to be here. Muito obrigado.
Oh, it's my pleasure. So, Ethan, we have 5 questions from 5 different specialists in Brazil. These questions are basically about clinical practice with medical cannabis. So just to put in perspective, the National Agency of Health Vigilance in Brazil set up by the end of 2019 new rules about medical prescription of cannabis and research in Brazil. Essentially, these rules are transforming Brazil into a solid prescription market, potentially including medical cannabis to patients in our universal healthcare system. So the goal here is to have your personal view about the role of cannabis for patients in palliative care. And I selected questions from Brazilian specialists, so I will transmit those questions to you now. The first question, it's a clinical practice question from Dr. Alexandre Kalp. Dr. Kalp is a neurologist. He is a researcher at the Albert Einstein Hospital in São Paulo, and he is interested in study of chronic pain. He specifically nociplastic pain. He's conducting the first clinical trial with CBG for chronic migraine in Brazil, which has been recently registered in clinicaltrials.gov. And his question is, Dr. Russo, considering the extent of outcomes to be observed in using cannabinoid-based medicine in palliative care, especially in cancer patients, what approach do you think would be more appropriate? The first approach, to prescribe cannabinoids despite the absence of strong recommendations, considering the possible general benefits in this treatment, like insomnia and other symptoms, or only prescribe cannabinoids after proceed to extensive randomized clinical trials?
Well, it's a bit of a loaded question. For most physicians, they're only going to be comfortable using a preparation that's received regulatory approval. In other words, that it's shown the safety, the efficacy, and the consistency to merit their use in a patient. However, in cancer, it's a bit of a different situation. These are people that usually are facing a terminal condition. Additionally, they are having very impaired quality of life. So they are in dire need of help with multiple symptoms that invariably are going to include pain, nausea, difficulty sleeping, depression, anxiety. As I think everyone is aware, there's no single approved medicine that's going to supply all those benefits. Whereas cannabis-based preparations certainly can help some with each of those, as well as others. And there is the promise, not yet fulfilled, of treating cancer as primarily with cannabinoids, usually in high doses. But this is, again, an active area of research. If it is allowed in a given jurisdiction, I'm in favor of trying things even prior to regulatory approval. And at this point, that's possible in many countries around the world with a liberalization of policy in this regard. And certainly all of us have heard testimony from countless patients and families about how much palliative benefit cannabis-based medicine had offered to someone in their family. So at this point, that's certainly what I'd like to see happen. But that also doesn't preclude the development of pharmaceuticals that would have the regulatory approval. And certainly when that occurs, it's going to have more ready acceptance by the medical community.
Fantastic. Just to mention, it has been published just in the end of September, a practical guideline at the BMJ, British Medical Journal, about cannabinoids and chronic pain. And the debate is very interesting because they show the evidence, and they gave a weak recommendation for using of cannabinoids. But when we do a benchmark with the other things that we prescribe for patients, I think that's an option for patients with very, very complex symptoms, as you mentioned.
Sure. Yeah, I would say that I found those guidelines very limited. You know, I think our experience, especially here in the United States, is that these drugs are a lot more helpful for pain than the clinical trials would seem to indicate.
Yes.
Part of that is an internal problem, and that is over the course of the last 30 years, we've seen increasing placebo responses in pain medicine or any drug that has a psychoactive effect. And it's gotten to the point that even drugs that obviously work are not able to demonstrate their efficacy because of these lofty placebo responses. In the case of cannabis, this is attributable to its reputation as a miraculous drug. And I think that's harmful. We have to have realistic expectations with anything we give our patients, particularly in a clinical setting. The advice should be, we're going to have you try this. We hope it will be helpful, but we need to see. Rather than saying we have a great new thing and it's obviously going to help you. This will again influence patients' responses. But there's another factor as well. Certainly in these meta-analyses, like the one that BMJ did, the real focus is on subjective pain scores. And that only goes so far. This is really not the strong suit of cannabis-based medicines. When we really look at this critically, really the benefit seems to come more from its effect on the affective component of pain. In other words, patients will report that the pain is still there, but it doesn't bother me as much. And this is very transforming in that people find that they can cope and they can function better. And this is key to a successful medicine. So certainly if we have strong opioids that will reduce subjective pain levels, coupled with a medicine that has these other benefits on the affective component of pain, this can be a very powerful combination, as well as the ability of cannabinoids to produce opioid sparing and thereby reduce attendant side effects. That also is going to contribute very markedly to the patient's quality of life. So I think that prior studies have really looked at the wrong outcome measures. and haven't given cannabinoids their due as to what they can really accomplish for patients.
Very interesting, fantastic points. And the second question is from Dr. Renata Freitas. Dr. Freitas is the medical director of INCA 4 National Institute of Cancer here in Rio. This facility take care of patients with advanced cancer. And she is dedicated to treating patients with advanced cancer. And she has extensive experience in palliative care and public policies for patients with cancer. Her question is also very, very straightforward. It's about one of the symptoms that usually happens in patients in the end of life, which is respiratory distress, dyspnea. And she asks, is there any perspective or studies already end-of-life dyspnea, respiratory distress, to access comfort, resulting in the need of delay of controlled sedation? Just to put in perspective, around 70% of patients in the last 6 weeks of life, they experience dyspnea. And it's a very complex symptom. Sometimes the patient doesn't have a dysfunction. It's just anxiety that they're feeling, and they're afraid to sleep. And it's a problem for both patients and families. So the last measure on this road is to put patients on controlled sedation, which is a problem because it interferes with the communication, interaction with family. So do you think that we can use cannabinoids to delay controlled sedation or to give more comfort for patients with dyspnea?
Right. So the answer is quite possibly. I don't recall any studies in that exact context. However, there has been some work on dyspnea of other causes, such as in chronic obstructive pulmonary disease, and specifically looking at air hunger. You've already made one of my points that some of this is related more to anxiety than it is to an actual diminished pulmonary reserve. I think that we should also mention that THC is a bronchodilator. So if there were any bronchospastic component, this could help there. There are other components such as alpha-pinene that are also bronchodilators, if that's present in the cannabis. And then again, dealing with the affective worry in this regard. People get panicky and also then get short of breath. Certainly very low dose THC could help there. Higher dose cannabidiol could help. And also we're finding a great deal of benefit, tremendous benefit from cannabigerol where it is available in treating anxiety without concomitant sedation. So I think this is certainly worth a try in that context. And again, if we're not sedating the patient and they're having relief of their dyspnea, I think that this would greatly benefit quality of life in the closing weeks.
Fantastic, thank you. And the third question is from Professor Eline Mateus. Professor Mateus, she's a PhD in psychopharmacology, and she's professor of Federal University of Rio. She works at the Institute of Biomedical Sciences, and she coordinates the Parkinson's Cannabis Research Group here in the Federal University, which I am in this group too. So I work with her in this group. And her question is, I think it's a very, very important and fair question. It's about polypharmacy. So we know that patients with cancer, sometimes or most of the time, we have to choose different analgesics, different drugs to treat these patients. So do you think that the cannabinoids, they really have the capacity of reducing the dose of other drugs, specifically opioids?
Yes, absolutely. First, let me mention that in terms of drug-drug interactions, I am going to say flatly that there's no drug that cannot be used concomitantly with cannabis-based medicine. Now, there has been concern in immunotherapy for cancer, but in the palliative patient, I think it's unrealistic in most instances to think that further cure is possible. But we know that extremely high dose cannabidiol, such as with Epidiolex used to treat severe epilepsy, can produce some drug-drug interactions with anticonvulsants, in particular valproic acid and with clobazam. But aside from that, I can say that in the entire Sativex development program, we had no significant drug-drug interactions. Now, in those studies with cancer, they were not designed to show opioid sparing because the patients were generally asked to maintain a steady dose. However, there are a wealth of studies now, observational, many from Israel, attesting to significant dose reduction in opioids and people with chronic pain, with stable conditions, even discontinuation of opioids. I would also point to a study that really hasn't gotten the attention it deserved. This goes back some time, about 10 years. It was a safety extension study of Sativex in patients with cancer pain that was unresponsive to optimized opioids. And a very interesting thing happened. First of all, people have been concerned about the development of tolerance with cannabinoids, but in the Sativex or in the big small studies, there was no dose escalation over time. So that was one issue. But the more surprising issue was, as the patients gradually succumbed to their disease, and these were patients that were in a hospice setting, the expected increase in opioid doses prior to their demise never occurred. In other words, we didn't see dose escalation on the opioids as you would customarily in patients who were terminal. So even if the dose were not reduced, the expected increase was not there. So I think it's well established that there is this ability, particularly with the opioids, but we've seen the same thing with benzodiazepines used in the context of pain treatment and some of the other analgesics, but to a lesser extent. So lower doses of the anticonvulsants used to treat pain, et cetera. So again, this is a worthy goal. We're always worried about drug-drug interactions, and if you're able to reduce the doses of these other drugs, it is going to materially benefit the patient's overall status and ability to interact with their families.
Fantastic. And the next question is from Dr. Guzman. Dr. Guzman is a geriatrician. He's the president and founder of the Seccional of the National Academy of Palliative Care in Rio. And he's a member of Palliative Care of the Regional Council of Medicine in Rio too. And the question is, assuming that the cannabis-based products may be helpful in controlling neuropsychiatric symptoms in patients with dementia, and that in Brazil, the formulations available are mostly oil with low concentration of THC, and what do you think? Would you? He would like to know your preferences for this indication. So basically, for the treatment of neuropsychiatric symptoms of dementia, and the caveat that we have only low THC in Brazil. So, what's your view about this? And another question is: should we avoid THC for those patients? And what dose of CBD it's most beneficial for these patients?
Sure. Okay. Well, in fact, the greatest amount of work has been done either with THC itself as Marinol or with THC-based preparations. And these can be extremely effective in demented patients, particularly Alzheimer's disease. What has been noted are the following. Number one, decrease in agitation. Number two, better sleep. Number three, improved appetite. Number four is greater tractability. By this, I mean that the patients are easier to handle, and the nurses especially are very in favor of what they see with the patients, their reduced need for care, the ability to sleep through the night. Now, the very good thing is high doses aren't usually necessary. We're talking about 2.5 to 5 milligrams at a time. We're not talking about 40 milligrams of THC. CBD certainly can be helpful. The doses likely would be higher. I'm going to say probably starting with something like 25 milligrams, but especially in combination with a low dose of THC. So this is going to contribute in a number of ways. One, anti-anxiety effects. Two, antipsychotic effects. We end up using haloperidol and other drug neuroleptics to treat patients in these situations. Unfortunately, it's been shown that those actually increase morbidity and mortality in this patient group. Whereas I have no feeling at all that cannabis-based medicines are going to hurt in this way. Additionally, we know that the side effect profile of THC is going to be benefited by the presence of CBD and increase its therapeutic index. So certainly this is an approach that's being utilized by some families and a few facilities with Alzheimer's disease patients, particularly in California. This is the case, but again, I've heard countless stories of the benefit of even low-dose cannabis-based preparations in this context.
Fantastic. Just to mention, Dr. Felipe is using low-dose THC and CBD for their patients. So I'm following the results, and it's really amazing. So the patients sleep better for the agitation. Usually here in Brazil, we have the limit of 0.03% of THC, and typically with the ratio of 30 to 1 to THC. So it's using these formulations and the results are really, really impressive.
Sure. So say, for example, there were 2 milligrams of THC in the preparation, that would be 60 of CBD. I suspect that would be very effective for most patients. Exceptionally, it could be doubled. But so 4 milligrams of THC and 120 of CBD, likely very effective. Right.
Okay. This question is from my mentor, Professor Andrew Lees. And his question is, I must say that he was very thrilled when I told him that I was going to interview you. So he's a very enthusiastic of botanicals in medicine. So he has been in Brazil several times. He has been in Amazonia for studying ayahuasca, and he's the responsible for the approval of apomorphine in Europe for the use in Parkinson's. So he's very enthusiastic about this theme. And his question is, I would like to know which indications look most promising for cannabinoids in neurology, whether it will be possible to fund phase 3 clinical trials through venture capital, and whether you envisage a liberalization of non-medical use as a positive or negative regarding further clinical development.
Sure. Well, absolutely. I regard the liberalization as a benefit, particularly in neurology. Those of us in the field realize that a lot of what we do is experiment with patients and changing medicine every month when they come back and need something else. So anything that gives a better clinical response is a godsend to us. But in terms of what the most promising areas are, I would point again to Alzheimer's disease as a palliative, but there also is the promise that both THC and CBD may be neuroprotective and could slow down the progression of the disorder or even arrest it, because there has been basic science work to show interference with the development of these toxic end products in the brain under these conditions. So that's a real possibility, but extending that to other neurodegenerative disorders, particularly amyotrophic lateral sclerosis, motor neuron diseases. Again, there are two factors here. We're looking for two kinds of results. One is symptomatic relief of pain, spasticity, sleeplessness, and again, adjustment to disease. But the possibility, unproven yet, of slowing progression and extending life. I think that this is really possible with the right preparation, and it's a direction that we would like to go. So I, again, recognizing that our available drugs in these situations are not so great, I really hope that the powers that be will allow this kind of experimentation and formal clinical studies to see whether we're right about these suspicions.
Fantastic. And the last is my question. You recently published a small survey conducted on patients using CBG. How do you see the development of clinical research involving CBG? And what would be the main indications to be explored? And do you think that CBG is a new frontier?
Oh, I do. I've called it the next big thing. So for people who are unfamiliar, cannabigerol is a parent cannabinoid to the others. Usually the plant doesn't spend a lot of time on it. It goes on to the others, but there have been varieties of the plant that stop there, just make cannabigerol. So particularly in the United States, we published a study, it's not quite out yet, with 127 patients who are using CBG predominant preparations, so at least 50% CBG. And the results that they claim were quite amazing in terms of pain, anxiety, depression, sleep, and not just that they thought that it was helpful, but more effective than conventional medicines for the same problems, with very few adverse events and no evidence of withdrawal when they stop the medicines. So all those things I mentioned are promising, but was not the two areas that may be the most exciting were not specifically examined in the study. We know that cannabigerol works on the TRPM8 receptor, TRPM8, which makes it a good target for treatment of prostate cancer. So that's one area. The other thing is that cannabigerol is a very effective antibiotic, particularly for gram-positive organisms, and including things like methicillin-resistant Staphylococcus aureus and vancomycin-resistant Enterococcus. And again, these are both areas of great research interest. And as they say, watch this space. I think in the future, we're going to have more news about these prospects.
Yes. Yeah, I've been prescribing CBG to my patients with Parkinson's. So the effect on sleep is amazing. So patients sleep much, much better. And the anxiolytic effect is also something that we don't see with other drugs in Parkinson's, specifically because Parkinson's patients, they have dysautonomia. It's a problem to prescribe SSRIs and other drugs that influences the blood pressure. So it's amazing. And I think that CBG also has probably an antipsychotic effect, because usually I withdraw sedatives, and in many patients I've been reducing neuroleptics. So I agree with you. I think the CBG is the next frontier in neurology. Absolutely. And my last question, I was reading your biography, and I was thrilled by the fact that you took a sabbatical in 1995 in Peru. So how was that experience? Was life changing for you?
Oh, yes. I already knew that I was extremely interested in ethnobotany, particularly in relation to alternative medicines in neurology. But it was a tremendous experience, and I'm fascinated by plant medicine, and it's remained an interest. I'm not just working on cannabinoids, but on a cultural level as well, seeing how these people who are extremely intelligent have adapted to life in a very harsh environment, extracting basically all their food and medicine from the environment. And the same would be true for indigenous people in Brazil. So, I'm also an ardent conservationist and environmentalist, and I hope that this knowledge among your people can be generalized to help other people who may think that medicine only comes in a bottle.
Fantastic. Well, we just reached the end of this interview, Dr. Russo. Thank you so much for your time. I know that you are a very, very busy person. We are all busy. So to take time for this hour, it means so much for us, for all the scientific community here in Brazil. And I can only thank you very much for your time. Thank you.
It was a pleasure. Thank you for the opportunity.
My pleasure.